Okay, great, wonderful. Before I give my presentation, I just wanted to give you some references because a pediatric chest trauma is such a broad topic. I'm trying to present everything within 45 minutes today. If you need some more detailed information or other imaging findings, you can actually have these references. So I wanted to kind of provide you with references before I start my presentation. So just a little bit of the background information, why pediatric trauma evaluation is important when it comes to radiologists and any of the clinician taking care of children who actually had thoracic trauma. Trauma is actually number one cause of the death in children, believe it or not, statistically older than 1 year old age. And secondary to brain injury is actually chest trauma is the most common cause of the death related to any of the trauma, mortality rate can be up to 20% of the time. As a radiologist, particularly dealing with pediatric patients with a chest trauma, very important for us to recognize some pattern difference in comparison to adult population. Anatomically, as we know, because of increased compliance of the pediatric chest wall, the findings are different in adult patient with chest trauma and pediatric patient with a chest trauma. And statistically, blunt force trauma is more common than penetrating injury in pediatric population. So something to remember for us, because imaging finding will be different based on the type of the trauma. When pediatric patients are presenting in the hospital setting for a potential chest trauma, I think the imaging evaluation becomes particularly important for initial diagnosis, which need to be prompt and accurate, which is associated with optimal patient outcome. And also, after a patient was managed, we provide with the imaging evaluation a follow-up assessment. Given the limited time that I have today, it's a 45 minutes to talk about such a broad topic. I really want to focus on three areas. First of all, even though most of us interested in imaging findings, it's important for us to know imaging guideline. So when you encounter a pediatric patient with potential chest trauma, you know what to do. So I'm going to talk a little bit about imaging guideline or algorithm. Also, knowing imaging technique becomes particularly important. So I'm going to actually spend a little time on imaging technique. But main portion of my presentation will be kind of looking at characteristic imaging findings associated with chest trauma in pediatric population. And as we know, nowadays, AI is getting a lot of attention, and that also applies to pediatric thoracic trauma evaluation. So, end of my presentation before conclusion, I'm going to just give you a little bit of like where we are in terms of the AI for evaluating chest trauma in pediatric population. So let's first start with imaging guideline or algorithm. So when pediatric patients are presenting with potential chest trauma, I mean, it could be just related to history. For example, there's a car accident, patients are coming, and then we have to do imaging assessment. Or patient may be symptomatic. I fell yesterday and now I have a shortness of breath and then the rib is hurting. Patient may present with known history a physical examination finding, so it could be unconscious. No matter what, I think that when pediatric patients are presenting with potential chest trauma, we do a chest radiograph as initial imaging modality, guides you to further assessment or management of the patient. Just wanted to briefly talk about other imaging modality as a screening or first initial imaging modality. A lot of people are actually asking you about what is the role of fast ultrasound. People sometimes do in ER, but when it comes to pediatric trauma setting, ultrasound really does not have important role as an initial screening imaging modality because all they show is, I mean, pleural effusion or hemothorax, but it really requires complete assessment. So it doesn't really have a important role when it comes to ultrasound. And very same thing with angiogram. A lot of times we do see something on chest radiograph and CT. For example, vascular injury, and we have to do management embolization. But now, not as a first imaging screening imaging modality. And same thing with MRI, because less availability, it takes a long time to scan, and at the same time, patient with potential chest trauma in the scanner room during the scan, a patient can actually, have a severe symptom, and then it's really hard to manage in the MRI scanner room. So MRI doesn't really have important role as a initial screening imaging modality. So once chest X-ray is done, a lot of times, if there's a abnormal findings or there's a symptom that is not really explainable, we do chest CT for further assessment and characterization, which is much more sensitive and accurate in comparison to chest radiograph. I think because of that, even though there's a increased risk of ionizing radiation exposure with the CT study, CT is current study imaging modality of the choice for complete assessment of chest trauma in both pediatric and adult population. A couple of years ago, one of the study nicely demonstrated the fact that chest CT is performed in comparison to chest radiograph alone. Additional diagnosis can be made up to 43% of the time, and that actually changed clinical management up to 70% of the time. So it really affects actually patient care. One of the examples that I wanted to show you to you a couple of years ago, we had a 13-year-old girl presenting with motor vehicle accident and then pretty good quality, post-trauma chest radiograph. ET tube was in good position, NG tube in the stomach. We didn't really see that much in the lung. Lung's pretty good to us. But of course, everyone kind of recognized there was a fracture involving the proximal humerus, so humeral neck, as you can see here. That's what's actually causing patients problem. Clinically, interestingly, a patient was not only complaining a left side of the shoulder pain, patient actually had a more shoulder pain on the right side. And I think that this is one of the challenges with trauma X-ray. A lot of device is overlapping it. But when we looked at carefully, like right humerus looks okay. And eventually it becomes more like a pleural chest pain or right-sided chest pain. So we look carefully about whether there's any pneumothorax or even we thought about could that be fat embolism type of picture because of, there's a like humeral fracture. But anyway, we did a CT study and of course, we picked up a humeral head fracture, but at the same time, it was undiagnosed. There's a non-displaced fracture involving the scapula, as you can see here, causing patients very severe symptom. No wonder patient was complaining about the right side of the chest, which was not really related to pneumothorax or even fat embolism. So in some situation, as you can see here, unexplainable symptom after trauma can be kind of easily recognized and diagnosed with a CT. So they have some important role when it comes to trauma. We're going to spend a little time on imaging technique. As I mentioned to you before, a chest radiograph is typically used as an initial screening imaging modality, like a first step to do. Hopefully, patient can stand up. We can perform upright and lateral view, which is very helpful. But a lot of times, particularly in the setting of the polytrauma, there's a lot of injury everywhere. They're on flat on the bed. It's really hard for them to kind of stand up. Because of that, we typically obtain supine frontal view. It has some limitations, but that's kind of what we actually are able to get. When it comes to CT study, as I mentioned to you before, for the complete assessment and characterization, and also sometimes problem solver after chest radiograph, of course, very important to obtain chest CT with a low radiation dose technique as much as possible. But I'm not going to go into detail about the imaging technique of the CT, but important thing is the fact that doing the right protocol becomes particularly important. Most of times we do CT study with contrast because we want to look at the vascular structure. But particularly if you have for example, plain radiograph with the widened mediastinum and one of your differential diagnostic consideration is a mediastinal vessel injury that I'm going to talk about and show you a little bit later. Important to do CT angiogram type of the protocol because it has a better visualization and evaluation of actually vascular structure. A lot of people ask me about injection rate when we perform CT angiogram. So I just want to quickly show you just a nice table demonstrating injection rate actually go up to pretty high, depends on the catheter size as it becomes larger and more stable. And then you can do mechanical injection, which will provide you with homogeneous contrast enhancement within the vascular structure, providing you with optimal imaging assessment. Okay, so now we talk briefly about imaging guideline and imaging techniques. We're going to talk about kind of fun part, kind of main focus of our presentation, which is actually imaging findings. A variety of anatomic structure can be actually injured in the setting of chest trauma in pediatric population. So important to have a category in your mind. Okay, systematically evaluate, the structure. First of all, you definitely want to think about lung parenchyma and pleural injury, as you can see here. And we should not also forget about some potential mediastinal or vascular injury, which do also occur in pediatric population. And of course, we should not forget about bone injury. So now we're going to go one at a time. First category we're going to look at parenchyma and pleural injury. And we're going to start with the lung contusion. Lung contusion is actually most common injury from blunt thoracic trauma in both pediatric and adult population. Unlike other population, I think that children are most susceptible because of greater pliability of the chest wall. It's more kind of weak and moving along more often in pediatric population. Depends on the literature that you look at. Lung contusions are typically seen up to 17 to 70% of the time. Wide range of it, right? But it's a very common, and then you should have clear idea about how they look like, on particularly on plain radiograph of the chest and also CT imaging. Here, one example, a large pneumothorax. Because of that, they put the chest tube on the left side, but the right lung, there's a airspace opacification. CT nicely demonstrate patchy opacity with some subpleural sparing, as you can see here. And this was actually kind of characteristic imaging appearance of lung contusion related to trauma. And underneath the pathology, typically all this opacification is due to hemorrhage, edema, or alveolar collapse, just a combination of it. It takes some time for this lung contusion to occur, but by the time when they come to hospital get the imaging studies, they usually it takes like, several hours, but within 6 hours, you should see this lung contusion. So how fast these lung contusion usually resolve? Of course, it really depends on patient population and type of the injury and how well they're recuperating. But typically, within 2 weeks, they should be resolved. So if it's getting worse, you want to think about something else. Could there be some superimposed infection or even aspiration rather than pure lung contusion in recuperating pediatric patient? Another important lung parenchyma injury that we should keep in mind is a laceration, right? So here, unlike a lung contusion, you see this linear lucency. Sometimes it could be by itself, or it could be associated with adjacent lung parenchyma hemorrhage, opacity, as you can see here, or even lung contusion. A small one, particularly if it's not associated with other lung findings, hemorrhage or contusion, it's completely easy to miss on chest radiograph. So we have to pay very close attention to it. Usually, small lung laceration without complication, patient do really well. But if there's a persistent, particularly, you see like pneumothorax associated or pneumomediastinum getting larger and larger, back of your mind, you want to think about could there be some associated, complication? And the most common one is actually bronchopleural fistula connection to those lacerated portion of the lung, pleura to the large airway. So if it's not resolving, getting worse, pneumothorax or pneumomediastinum in the setting of the trauma with the patient with the laceration, you probably want to have like cross-section imaging study or even bronchoscopy to make sure there's no bronchopleural fistula which need to be managed. Moving on to pneumatocyl, practically those are the round, oval-shaped collection of the air. Sometimes they may have an internal fluid, and typically associated with lung laceration and lung contusion. So one of the example here, the patient had a little laceration and lung contusion involving the lower portion of the chest, here, left lower lobe, and eventually it actually developed lung pneumatocyl, as you can see here, with the 3D volume rendered images nicely demonstrating it's actually connected to adjacent bronchi, as you can see here. Once again, with the lung laceration, If you actually see worsening associated pneumothorax, pneumomediastinum, which is not really getting better, even though there's a chest tube placement or mediastinal drainage catheter placement. So when you see that, back of your mind, once again, you want to think about, could that be a complication? There's a pneumotostill, whether that's actually communicating with adjacent large airway and resulting in bronchopulmonary fistula. So those patients may need to go surgery for the management. Most important complication, now we're moving on to some pleural injury when it comes to chest, pediatric chest trauma is of course pneumothorax, right? Which can occur up to 30% of the pediatric patient with lung trauma. It really depends on size and location, and then also whether there's any associated complication, particularly like a tension components. Mortality rate varies, but statistically, at least moderate to a large degree of the pneumothorax. And usually those the one have associated other injury, have a mortality rate up to 16% of the time. Very important to recognize. A lot of times it can be due to underlying alveolar rupture, pleural laceration, and then particularly when it comes to chest related to adjacent rib fracture, kind of penetrating injury. And we're going to talk about a little bit later, but large airway injury, bronchial or tracheal injury can actually, cause a potential problem. Small and moderate size of the pneumothorax, to be honest with you, in pediatric population, can be actually easily missed on kind of not optimal chest radiograph performed on supine view. So we're going to talk about a little bit later, but the AI could be really helpful for detecting those small or moderate pulmonary pneumothorax, which may be actually missed by the radiologist. And the increased confidence level and diagnostic accuracy level can be really helped by the AI. I don't know why we're getting all these like little red lines. I don't know whether you can see it. But anyway, so one of the study that we have done a couple of years ago, it's kind of earlier part of the AI. We were able to do some automatic segmentation of the trauma-related pneumothorax, as you can see here. So with the automatical system, chest CT with the pneumothorax can be actually, pneumothorax can be detected, they can be measured, and they can be segmented, and they can be correlated with the clinical outcome. So it has a kind of very important role, but now it's kind of evolving into AI that I'm going to talk about a little bit later. Okay, so now we're going to move on to the pleural injury, which is actually one of them important ones actually, hemothorax. So practically, by definition, hemothorax represent underlying blood within the pleural space, which is kind of trauma related to it. It can be due to three important, underlying causes. Could that be penetrating injury? Could that be laceration from the adjacent rib fracture that we talked about? Or it could be just tearing from rapid deceleration, in the setting of the trauma. The way that we can tell whether we're dealing with a simple effusion or whether we're dealing with complex, including hemothorax, is you actually put the Hounsfield unit. Simple water on CT should be less than 20 Hounsfield unit. But when it comes to hemothorax, when you put the Hounsfield unit, it becomes higher than water attenuation. Here in this particular case was actually 64. So you knew that this was actually not simple effusion. And this was actually drained with a chest tube. And then, the clinician reported to us that like the blood was actually coming out. So definitely there wasn't actually simple pleural effusion. Hemothorax commonly associated with a rib fracture, particularly penetrating one. So whenever you see that, you want to pay close attention and to see possible hemothorax. And another interesting thing about this hemothorax, particularly in pediatric patient in the setting of the trauma, is that a lot of times, even though you do see the angiogram with the delayed images, you may not see like active bleeding. So you just, just because you don't see it, but if you see like the very high dense pleural effusion in the setting of the trauma, you definitely want to have a high clinical suspicion for a possible underlying hemothorax, even though you don't see active extravasation on CT imaging. Now we looked at parenchymal and then pleural injury. We're gonna move on to our next category, kind of middle portion of it, which involves mediastinal injury and vascular injury, which is relatively kind of rare compared to parenchyma and pleural injury in pediatric population, but important one that we should not really miss and that we should know exactly the underlying causes. For example, mediastinal injury when it comes to tracheobronchial injury. So, when you look at statistics, it's less than 1% of the pediatric blunt thoracic trauma patient will have tracheobronchial injury. But importantly, there's a delayed diagnosis up to 25% of the time. And because of the rarity and we don't really pay attention, particularly plain chest radiograph, I think that's probably the cause. But important thing is that because of the delayed diagnosis usually associated with other severe injury, the mortality rate is actually up to 30% of the time. So very important to recognize it very early, during the evaluation. Here, plain radiograph nicely demonstrating getting worsening, subcutaneous emphysema, and then there's a mediastinal air getting worse. So they were kind of suspecting, possible trigger bronchial injury. When they did perform CT imaging, you can see there's a complete rupture of the trachea, and then air is actually accumulating kind of posterior portion of the trachea, and then into the mediastinum on top of a lot of subcutaneous emphysema. The most common location of the tracheobronchial injury in the segment of the trauma is just above the carina. So that's the area that you want to pay close attention. So the key point clinically with the possible underlying tracheobronchial injury, whenever you see pneumomediastinum or pneumothorax getting worse, even though there's a chest tube or drainage catheter placement, back of your mind, the air should come from somewhere, and one of the location could be potentially large airway. So you want to look at that area carefully. And the literature pretty much is saying the fact that, high clinical suspicion becomes important. But X-ray, in retrospectively, when you look at it, up to 15 to 20% of the time, just the position of the endotracheal tube could be actually off on the plain radiograph in patient with underlying tracheobronchial traumatic injury. So whenever you see that the location of the trachea, the endotracheal tube looks kind of odd, but you know that that's in the trachea, not in the esophagus, then back of your mind, you want to think about possible underlying tracheobronchial traumatic injury. What about aortic injury? Much more common in other population when it comes to trauma, rare in pediatric population, but do occur. There aren't that much literature out there, so some of the literature state less than 0.1% of the all thoracic trauma. I kind of agree with it, but you cannot not pay attention to vascular structure in pediatric population with a chest trauma because it does occur. And when it does, early detection becomes particularly important. Here, when you look at the mediastinum of this chest X-ray, it's really widened, right? This is an older pediatric patient, so it cannot be really thymus. It's just too old for that. So because of that, people were actually suspecting possible, vascular injury. When we did a CT here, you can see there's a descending aorta vascular injury. On CT, you're looking for kind of dissection flap, intraluminal thrombus. Then later, what happens is that here the patient would actually missed, or it was kind of not detected initial CT. Couple years later, people were very surprised with the mediastinal widening, and there's a pseudoaneurysm formation, as you can see here. Kind of sequela of undiagnosed or missed or subtle aortic injury that kind of passed by, and eventually becomes like pseudoaneurysm, as you can see here. A couple of key points that I want to mention to you regarding aortic injury. The common location is the ischemic portion of the descending aorta. So that's the area that you want to pay attention. And whenever there's a polytrauma, other body part, that kind of tell you there's a severe injury. So, pay also very closely attention to potential vascular injury. Okay, that leads us to a couple other consideration. So we're gonna look at a couple other potential problem that could happen kind of mid portion of the chest. So what do you think about this one? So heart is definitely abnormal, right? Really, really big. So here, a lot of people can recognize there's actually precordial effusion. But when you actually look at it, the density of the fluid is actually much higher, brighter, lighter than adjacent effusion, as you can see. So you know that that's probably not simply effusion. When we put the 100 unit, it came up higher than actually, 80. So this was actually hemopericardium. And it could be slow bleeding, but it could be really rapid. Doesn't matter. When it comes to more than like 300 cc within the pericardium, that's when people start to have symptoms with like cardiac tamponade. So very important to actually recognize it accurately and also drain it as much as fast as possible. What about this one? Anything bothers you? Okay. So I think that some people kind of recognize what's going on. So here, around the esophagus, you see this lucency. Do you see that here? And then also some mediastinal air. This was actually due to esophageal injury with the air coming through the esophagus. So that's another area that you want to pay very close attention. Rare but do occur in pediatric patients in the setting of the trauma. And then what about this one? So sagittal view of the CT that I'm showing you. So in the setting of the trauma, I'm gonna give you a little clue. So here, so that's a little clue, right? So aspiration can do occur. This was actually aspirated here in the esophagus. So these are the things that also, you need to pay very closely attention, not only just looking at the large airway or a vascular injury when it comes to middle portion of the anatomic structure abnormality that you may encounter in the setting of pediatric trauma. Okay, so now we looked at lung parenchyma and pleural injury and mediastinal and vascular injury. We're going to move on to osseous injury that can occur in pediatric population. And we're going to actually start with the rib fracture, which is relatively common. When you look at statistics, up to 50% of the pediatric patient with a blunt thoracic trauma coming to the hospital because they're symptomatic, they do have some type of the rib fracture or rib abnormality. But in comparison to the population, good news is that it's less common. The reason is because the pliability of the thoracic cavity, like the chest wall, because of that, refracture is less common in comparison to adult population. Everyone will recognize refracture, particularly on CT with the bone window images. Just a couple key point, so I don't have to, discuss in detail. But when it comes to first rib fracture, because at the thoracic inner level, there's a lot of vascular structure around the location, right? Because of that, you definitely want to pay close attention to a vascular injury. And when it comes to a low rib fracture, that's very close to upper abdomen. So in this patient with a low displaced low rib fracture, you can see there's a splenic injury as you can see here. So it kind of give you the clue, depends on where it's located, other structure that you have to pay close attention to in the setting up a rib fracture. Another type of the fracture that you may encounter is a compression type of fracture. Unfortunately, even though this is actually number one pediatric thoracic spine injury, vertebral body compression fracture, but usually it's underreported, and then somehow, if it's a mild degree, some people kind of don't pay attention. It's usually due to underlying anterior and lateral hyperflexion. And the important thing is that, as a radiologist, like a lateral view, for example, even though you have like the plain radiograph only, just looking at the lateral view of the, chest very closely, the spine becomes very important to pick up those compression fracture. And of course, when we do CT imaging, with the sagittal, reformative view, you can see the compression fracture and then degree pretty well. And then exhale, you can also look at it too. So very important to recognize compression type of the fracture. Okay, so just moving on to some of the other type of the fracture that you have to actually pay close attention to. So what about this one? So I just wanted to show you. So here, when you look at it, so those are the maximum intensity projection images, right? And then there's multiple refractures here, right? And then also not only just the one location with the multiple refracture, you can also see kind of with fracture posturally. So this patient actually presented with a paradoxical respiratory air movement. So whenever they actually, breathe in, breathe out, this segment of the, fractured or almost like a detached rib was actually moving paradoxically. So I don't know how many people are aware of it. So in this setting, it has a name. It's actually frail chest where the a segment of the portion of the actually chest wall, because of the multiple fractures surrounding it, kind of detaches, right? And then it's kind of paradoxically, moving whenever there's a respiratory movement. It can cause severe symptom. And if it's not detected early, actually very high mortality rate up to 36% of the time, depends on statistics. So very important to recognize not only just a rib fracture, but also whether entire segment of the rib or chest wall is actually involved. What do you think about this one? On the sagittal view, so here, looking at the spine, pretty looks good. So I do have to say the fact that a lot of people don't pay attention to actually a sternal fracture, as you can see here. So, a lot of times sternal fracture, if actually displaced posturally, if it's a sharp angle, they can actually cause penetrating type of injury to the anterior portion of the heart. I've seen in patients with a diaphragmatic injury associated with it, or kind of anterior portion of the high liver, upper liver. So very important to look at not only the spine and the sagittal view, but also the sternum. Of course, the first type of the fracture is another type of fracture that can be easily picked up with the cross-section imaging studies associated with thoracic injury. Okay, so now we're gonna move on to one question that I have for you. So this patient had a thoracic injury, thoracic trauma, car accident, and presented with this finding. So as you can see, your bone window images, we are looking from the top. And then clavicle is actually displaced. So this is just sternum, that's the anterior portion. And this is actually posterior portion and actually displaced posteriorly. So the question that I have for you is whenever you see this kind of posterior displacement or dislocation of the clavicle, even though the clavicle itself is not fractured, what potentially serious injury can be associated with this finding? So the choices that I have for you is actually spinal injury. Could that be diaphragmatic injury? Could that be cardiac injury? Or could that be vascular injury? I'm just going to give you a little time for you to think about it. So the question is, yeah, we don't see any fracture in the bone, but the clavicle kind of a medial portion is actually substantially displaced posteriorly. So what should we worry about? Hopefully, everyone actually picked the correct answer. And then the correct answer is actually vascular injury. Excellent, very good.
vascular injury.
Because of thoracic inlet level, there's a lot of structure like the first rib and then clavicle. There's a lot of vessel around it here, as you can see here, a brachiocephalic artery. There's active bleeding because of the clavicular displacement. So whenever you see that, you definitely want to have high clinical suspicion for underlying vascular injury, and CT angiogram type of the CT protocol may be optimized for evaluating underlying vascular injury. Okay. So getting close to end of my presentation. As I promised you before, just briefly talking about the future direction of like imaging evaluation of pediatric thoracic trauma. AI, artificial intelligence, is getting a lot of attention, as we all know. It's being actively developed and applied to thoracic trauma. I do have to say the fact that when you look at the literature out there, most of the studies are currently performed in adult population, but I'm sure it's gonna be, translated into pediatric population, relatively soon. And it has been demonstrated the fact that, when you actually use the AI, when you evaluate actually the thoracic trauma
أنا
setting,
هدي لها توثيق معي
it
من صوت الإقامة
enhances
هاي غلطة
actually
منها ما كان
imaging
أكل.
analysis, and also it can actually help risk stratification. And also, as importantly for radiologists, it can increase the diagnosis of the injury. So one of the things that actually, one of the study that looked at this a couple of years ago, and actually demonstrated the fact that when the radiologists are just performing detecting pneumothorax, particularly small to moderate pneumothorax, with and without AI. When you actually add the AI, the diagnostic accuracy performance becomes almost like 100%, like a complete. So improved. So I think that there's a probably important role for using AI, even for like evaluating pediatric thoracic trauma on plain radiograph and hopefully for the CT. But I'm sure there should be more study, it's going to come up, and then there will be a more data out there will help guide us to use AI correctly and optimally for evaluating pediatric chest thoracic trauma setting. Just a key area of the application of the AI in the setting of the thoracic trauma. So far, most of them are based in adult population, but evaluating rib fractures, pneumothorax, and also hemothorax, and then lung contusion. So those are the four areas, kind of so far proven to be improving the diagnostic performance of the radiologists when they use AI in combination of their independent interpretation. Okay. So given the limited time that we have today, 45 minutes, we talked about imaging evaluation of pediatric thoracic trauma and a couple take-home point that I want to leave with you today. Just the basic, information, background information. It's actually leading cause of the death in pediatric population in just anywhere in the world. So you definitely want to pay close attention to imaging characteristic and understand how they look like. Unlike other population, as I mentioned to before, anatomically, there's increased compliance of the pediatric chest wall, for example, because of that. Refracture is relatively less common in comparison to the other populations. So you want to remember some differences. And statistically, blunt force traumatic injury is much more common than penetrating trauma. And as a radiologist or any of the clinician taking care of pediatric patient with potential underlying chest trauma, very important to recognize characteristic imaging appearance and any anatomic structure, as I mentioned to you before, categorically, lung parenchyma and pleural injury, mediastinal involving the airway, or it could be, vascular structure, and also osseous structure becomes particularly important, and hopefully in near future, with the, more advances and development of the AI. We could be using AI, which could be helpful for evaluating, better assessing pediatric thoracic trauma type of injury in pediatric population. So thank you very much. I think it's 11:40, so I think I finished it on time. Wonderful.